Good morning, class. For this morning, we're going to discuss disorders of the thyroid gland. So this session will be composed of 3 parts. So there will be 3 videos that I will be posting in my YouTube channel. So please watch out for them. So again, I'm Dr. Ana Angelica Macalalad Josre. And today, at the end of this class, you guys should be able to review the regulation of thyroid hormone synthesis. So I was supposed to discuss anatomy, physiology, but I will leave it up to you to read up on that so that we will have more time to discuss the pathologic parts of the disorders of the thyroid gland. So next, you guys should be able to learn how to approach patients suspected to have thyroid dysfunction and identify which diagnostic test to request in the evaluation of thyroid dysfunction and how to interpret them. So thyroid function test is one of the most common tests that is usually requested in the clinic, and it could be tricky to interpret them sometimes. And lastly, the bulk of our lecture will be recognizing the various causes, clinical manifestations, and treatment of number one, hypothyroidism. Next would be hyperthyroidism and thyrotoxicosis. And lastly, a little bit about thyroiditis. Okay, so central to the physiology of the thyroid gland is your iodine. So it's important to know that hypo or hyperthyroidism can be very much affected by the iodine levels in the body. And it's important for thyroid health that people would take iodine-rich foods in order to maintain thyroid health. No? So what are iodine-rich foods? You have dairy, you have eggs, you have certain fruits like strawberries, cranberries, seaweed, navy beans, and of course seafoods. No? Seafoods, everything that comes from the sea can be a rich source of iodine. And the recommended and typical values of dietary intake are the following. So in adults, the recommended daily intake would be 150 micrograms. In pregnancy, the demand will increase, so it's required to have 200 micrograms. And in children, it's 90 to 120. So it's important to remember this because I usually ask this in the exam. Okay, so worldwide, no, um, despite worldwide fortification with iodine, no, there are still areas in the world that have iodine deficiency. No? So as you can see, um, the Philippines still have areas of mild deficiency. No, even if we are an archipelago where we have rich sources of seafood, no, and but iodine deficiency is quite common in mountainous areas where seafood is not very accessible. I think the area in the Philippines with the highest iodine deficiency will be in the Zamboanga Peninsula, surprisingly. And for my Indian students, note that India is tagged by the World Health Organization to have areas of moderate to severe iodine deficiency. So, what are the consequences of iodine deficiency? You can have a goiter, no? Because the thyroid gland will try to compensate by increasing its thyroid gland size in order to meet the demands for thyroid hormone in the body despite having iodine deficiency. If the iodine deficiency happens um, during the neonatal period or even during the prenatal period, the babies can have cretinism, where there will be mental and growth retardation in children, especially in areas with iodine, in regions where there is marked iodine deficiency. Um, these patients are not treated with iodine of thyroid hormone to um, children who are not treated with iodine um, with iodine of thyroid hormone to restore normal thyroid hormone levels during early age usually develop cretinism. So it's very important to identify um, iodine deficiency causing congenital or neonatal hypothyroidism in order to be able to correct it early on so that the patient will not develop cretinism. I had a patient before came to me because of goiter and hypothyroidism. And then I thought it was some like Hashimoto's thyroiditis, no? One of the more common causes of hypothyroidism. But when her neighbor advised her to take iodine, no? And on our follow-up, there was a marked reduction in the size of the goiter. And it's after all just endemic goiter or iodine deficiency. So let's just review the regulation of thyroid hormone secretion so that you will be able to grasp how to interpret thyroid function tests and how disorders of the thyroid gland works. No? So remember your hypothalamic pituitary thyroid axis. No? So this is controlled by a negative feedback mechanism, and the the synthesis of your thyroid hormones is very much affected by this axis. So your hypothalamus secretes your thyroid hormone releasing hormone or your thyroxine releasing hormone, your TRH, which stimulates the anterior pituitary to secrete your thyroid stimulating hormone. And in turn, your thyroid stimulating hormone will stimulate your thyroid gland to increase thyroid hormone secretion by the following mechanism. No? First, it increases the proteolysis of your thyroid gland. So thyroid gland is a storage form of your thyroid hormones. That's why actually our thyroid gland is unique because it can store thyroid hormones and therefore be able to supply your body with months long supply of thyroid hormone in case your thyroid gland um, have failure to synthesize and secrete your thyroid hormone, and this is because of the thyroglobulin, the storage form of your thyroid hormones. No, so if once your TSH binds to your TSH receptor, no, all of these are activated. So there's increased proteolysis of your thyroid globulin, there's increased activity of the sodium potassium iodide pump, therefore increasing iodine uptake into the thyroid gland. It also increases iodination of your tyrosine, increases the size, and increases the secretory activity of your thyroid cells. So that's why if you have, let's say, Graves' disease, where there is excessive activation of your TSH receptor antibodies, TSH receptor by TSH receptor antibodies, or in cases where you have TSH secreting pituitary adenoma, where you have excess TSH, increasing activation of your TSH receptor, you will have a goiter because of the trophic effect of your TSH, resulting in increase in the thyroid gland size and therefore increase also in the number of thyroid cells. And this is primarily mediated by your cyclic AMP. So there are some instances where there will be loss or gain of function mutations by your with your TSH receptor that can cause usually hyper or hypothyroidism. But those are very rare conditions, so you don't need to remember that. So as you can see in this slide that TSH affects almost each step of your thyroid hormone synthesis and secretion. So it's very important for you guys to review the steps in thyroid hormone synthesis and secretion. So usually I have a question on thyroid hormone synthesis, the steps in thyroid hormone synthesis in the exam. So please review that. No? So I talked to you about T3 and T4 being your thyroid gland hormones. And we'd like to compare what's the difference between your T3 and your T4. So it's not it's important for you to understand this based on your physiology so that you will remember it, but you don't really need to memorize this if you understand what this means, no? So your remember your T3 and T4 need have binding proteins in order to prevent its premature metabolism in the circulation, and the affinity to the plasma protein will be determined by your that will determine the activity of your T3 and T4. So remember that um, the predominant thyroid hormone that is released by your thyroid gland is T4, and your T4 undergoes peripheral conversion to your more active thyroid hormone, which is your T3. So the more active thyroid hormone is your T3. And your T4 has a higher affinity to your plasma protein, while your T3 has a lower affinity to your plasma protein because it's the more active form of your thyroid hormone. Since your T4 undergoes peripheral conversion to your T3 in the target tissues, no? Therefore, you will have a larger volume of distribution because your T4 is converted to T3 in the periphery or in your target tissue. Next. Ay, sorry. Um, the serum concentration of your free T4 is higher in your T4. T4 has a higher level of free T4 hormone simply because there is just a higher percentage of total T4 that is being secreted by your thyroid gland more than your T3. So therefore, there is a higher free T4 concentration also in your body. And as you can see here, the production rate of your thyroid gland will be greater with T4 compared to your T3. But it will be your T4 that will be converted to the more metabolically potent or active hormone, which is your T3. So remember that your T3 and T3 is the more potent, more active thyroid hormone, and because it is needed much by the tissue from peripheral conversion, it has a higher volume of distribution and therefore needs to have lower affinity to your plasma protein. The half-life of T4 is also greater than your T3 because your T3 is readily consumed by your peripheral tissue. That's why it has a shorter half-life. So remember I told you that the T4 that is the T4 that is produced by your thyroid gland when it reaches your peripheral tissues, it is converted in your T3. And more than 90% of thyroid hormone molecules that bind with your thyroid hormone receptors in your target cells will be your T3. No? So in the periphery, your T4, no, is acted upon by either your deiodinase enzyme 1 or 2 to be converted to your more active thyroid hormone T3, or it can be deactivated by your D3 or deiodinase enzyme 3, not to your inactive hormone, which is your reverse T3. So it will depend on the cell. If the cell has D1 or D2, it can convert T4 to T3. But if the cell has your deiodinase enzyme 3, it will deactivate your T4 into your reverse T3. So what are the effects of thyroid hormone on specific body function? No, as just as a review, it increases everything. It increases your metabolism in the body, including carbohydrate, fat, and protein metabolism. So in terms of carbohydrate metabolism, it increases glucose uptake by cells, enhance glycolysis, enhance gluconeogenesis, increase absorption from the GI tract, increase insulin secretion. No? So essentially, patients with increased activity of your TSH receptor, resulting in increased levels in thyroid hormone levels in the body, would have an exaggerated increased carbohydrate metabolism. Some of them will have hyperglycemia. They will have uh, when we go to hyperthyroidism, some of them um, will have hyperglycemia and hypercatabolism. No? There's also increased fat metabolism, and lipids are mobilized rapidly from the fat tissue, and there will be decreased fat store. So in patients with hyperthyroidism, this is a very much exaggerated as well. Most of patients with hyperthyroidism would have significant, no, significant weight loss. Um, and also some form of muscle wasting. This is because of increased protein synthesis and degradation caused by your thyroid hormones in the body. And the resulting physical manifestation is a decrease in your body weight. So the overall effect of thyroid hormone is catabolic. No? So patients would have hypercatabolism. How about on the nerve effects on the nervous system? So your thyroid hormone levels has excitatory effects on the nervous system. So in hyperthyroidism, patients will have hyperexcitability, irritability. In patients with hypothyroidism, it will be the opposite. There will be listlessness, slowed speech, somnolence, impaired memory, and decreased mental capacity. In the autonomic nervous system, your thyroid hormones upregulates alpha adrenergic receptors in the heart. So patients will have, usually have tachycardia, no? Sometimes tachyarrhythmias. In sleep, no? Patients usually will have difficulty sleeping because they're always hyperexcitable. Their mind is always running all the time. And in hypothyroid patients, they will have extreme somnolence. And sometimes the patient comes to your clinic, no, very sleepy, no? You know that these patients are hypothyroid. So the spectrum of thyroid dysfunction will range from your overt hyperthyroidism to your mild, no, subclinical hypothyroidism. Usually you just see this in biochemical tests. And then on the opposite end of the spectrum, you have your subclinical hypothyroidism, which is your mild hypothyroidism, and then your overt hypothyroidism. So how do we evaluate in the laboratory if you suspect a patient to have thyroid dysfunction? Let's say a patient comes to you with classic symptoms of hyperthyroidism like palpitations, tremors, significant weight loss. No? Or on the other hand, you suspect a patient to have hypothyroidism. So for example, a patient has underwent thyroidectomy with no thyroid hormone replacement, or any patient presenting with goiter. This is how you evaluate the initial evaluation of this patient. So the first step is to check TSH levels. TSH is the most sensitive marker of thyroid status, and a normal TSH level usually excludes primary thyroid pathology. So if there's really a thyroid dysfunction, there could be a possibility that it's a secondary hypothyroidism. So if your patient does not have any money at all and you only have like 500 pesos to spare, please choose TSH, no? For the initial lab evaluation. Of course, if it's monitoring, it will be different. If the TSH levels is abnormal, you can proceed to check your FT4. No, not your T4, your FT4 and FT3. If your TSH is suppressed, your T4 is normal, then that's the time you can check for your FT3 or your total T3 to check for T3 thyrotoxicosis. No? So this, you only request T3 if you're suspecting T3 thyrotoxicosis, or in some cases if you're suspecting CQ thyroid syndrome or your non-thyroidal illness. So again, this is my advocacy with my med students. You don't need to always measure all three at the same time because unnecessary tests cost money and resources. Usually, you just need TSH and FT4. If the likelihood if thyroid dysfunction is very low, just check TSH. No, if the TSH is normal, then you can say most likely the post-test probability of thyroid dysfunction is very low. Sometimes if there is a high index of suspicion for, for thyroid dysfunction, then you can actually check TSH and FT4 already at the same time so that you will save your patient from multiple blood draws and multiple visits to the laboratory. But if the pre-test probability or this is that the chance of a thyroid dysfunction is low, then just do a TSH, no? And you only have to choose patients that need the FT3 or your total T3. So please, I know you will see when you go into the clinics, you will see residents or even consultants, no? That's not in endocrinology, they just request the three right away. That's a bad habit. So do not emulate that or do not follow that. You just check TSH and or T4 and T3, T4 as necessary. Okay? So let's try to interpret your thyroid function test. So let's say now you have a patient referred to you or coming into you at the clinic with, let's say, a suppressed TSH and an elevated T4. And how would you interpret that? So that will be your overt hyperthyroidism or your primary hyperthyroidism. What if your patient has a suppressed TSH and a normal FT4? So this is the one of the instances where you could suspect T3 thyrotoxicosis, meaning your T3 is the one causing the suppression in your TSH. So that's the time you request for your T3. So you can have, if the T3 is elevated, that's what we call T3 thyrotoxicosis. If your patient has a suppressed TSH and a normal T4 and your T3, T4, your total T3 or FT3 is normal, then you can have subclinical, that's the time that you will have subclinical hyperthyroidism. So remember that the basis to determine whether this is hyperthyroidism or not will be your TSH, okay, not your FT4, okay? If the TSH is suppressed, no, but your T4 is normal, then that's what we call subclinical hyperthyroidism. What about if the TSH is elevated and your FT4 is normal? What do you call that? So just like your subclinical hyperthyroidism, this is what we call your subclinical hypothyroidism. It's hypothyroidism because the TSH is elevated, but it's only subclinical because the FT4 is still normal. If your TSH is elevated and your FT4 is now low, then that's what we call, no? This is, since the TSH is elevated, it's hypothyroidism, but this time this is your overt hypothyroidism or your primary hypothyroidism, meaning the pathology is coming from your thyroid gland, primary hypothyroidism. What if you have a normal TSH and a suppressed T4, a low T4, no? It's not subclinical hypothyroidism. This is what we call isolated hypothyroxemia. So there is an isolated low T4 levels with no corresponding suppression of your elevation of your TSH, no? Because in if you have a low T4, we expect your TSH to be high, but this in this case the TSH is normal, so you just have isolated hypothyroxemia. Thyroxine is T4. If you have a normal TSH and an elevated FT4, what do you call that? So that will now be your isolated hyperthyroxemia. So when you have an elevated FT4, you expect your TSH to be suppressed. But in this case, the TSH is normal. So you just have your isolated elevation of your T4 or your isolated hyperthyroxemia. But remember that these are not diagnoses. No? This will just help you in arriving at your differential diagnosis from your thyroid function test interpretation. So for example, your patient presents to you with overt hyperthyroidism. There will be many causes for overt hyperthyroidism. So overt hyperthyroidism or primary hyperthyroidism, it's not a diagnosis, it's just a condition. Usually, you have, let's say, primary hyperthyroidism secondary to Graves' disease, and your Graves' disease is your diagnosis. Okay? So what are the tests used to determine the etiology of thyroid? Other tests, no, to determine the etiology of thyroid dysfunction. So, for example, you have a patient who is determined to have primary hypothyroidism. You can request for anti-PPO if you're considering autoimmune thyroid disease, particularly your Hashimoto's thyroiditis. Anti-PG, you can also request in patients who suspect to have autoimmune thyroid disease, although this is not commonly requested. And of course, you have your TSH receptor antibody. This is the antibody that we test if we suspect to have a patient with Graves' disease. Or usually this is a very expensive test. So usually we reserve this TSH receptor antibody in cases where the diagnosis is still unclear despite initial tests. No, the diagnosis of Graves' disease is still unsure. No, if despite initial laboratory tests. We also request your TSH receptor antibody during the last trimester of pregnancy in order to predict neonatal thyrotoxicosis. We can also request for serum thyroglobulin, and it's usually elevated in all types of thyrotoxicosis except thyrotoxicosis factitia. So thyrotoxicosis factitia usually from exogenous intake of thyroid hormone. So these patients will manifest with will manifest with thyrotoxicosis, no, but the thyrotoxicosis not from endogenous thyroid hormone secretion, but from an exogenous, usually with intake of levothyroxine. And because the source of the excess thyroid hormone is exogenous, so your serum thyroglobulin, which will indicate that the source of thyroid hormone will be from the thyroid gland, will be low. No? So if you suspect thyrotoxicosis factitia, no, you can request for a serum thyroglobulin. But the more important use of your serum thyroglobulin will be its use in post-op surveillance monitoring in patients with thyroid cancer. Remember, your serum thyroglobulin indicates the presence of thyroid hormone activity, thyroid gland or thyroid cell activity. No, so if it's still detectable even after your thyroidectomy, your radioactive iodine therapy, if your serum thyroglobulin is still detectable, there's a possibility that there's tumor recurrence because your thyroglobulin is produced by your thyroid cells. No? But if the thyroglobulin is undetectable, then most likely the thyroid cancer is under control or potentially in remission already. So how do we monitor treatment? So we talked about how to diagnose patients, what are the initial laboratory testing. How about when the patient is already undergoing treatment, how do we monitor them? So we only need to check either TSH or FT4. So if TSH, if your patient has primary hypothyroidism and you are already giving the patient levothyroxine replacement, we request only for TSH to determine whether the T4 replacement is adequate, whether your levothyroxine dose is need to be adjusted or not. No? So remember, if it's hypothyroidism, you only monitor your TSH. You only check as early as 6 weeks or every 3 to 6 months if not clinically hypothyroid. So you don't request for TSH every week or even every 3 days because you don't expect the TSH to move. No? Let's say you adjust the levothyroxine today, you request after 1 week, it will be the same because it will only change as early as 6 weeks only. No? So in patients with chronic hypothyroidism, the control is quite good, no, very small elevations in your thyroid, very small abnormalities in your TSH. You can actually monitor these patients every 6 months, even once a year, no, because studies have shown that only small changes in your thyroxine doses doesn't really have a significant effect in the overall quality of life of patients. In patients who have, on the other hand, in patients who have central hypothyroidism, no, in patients who have central hypothyroidism, um, we request FT4 to check for adequacy of levothyroxine replacement. Because in central hypothyroidism, meaning the problem is in the pituitary, the TSH levels becomes unreliable. So we use FT4 to monitor whether our patients is adequately replaced in terms of their thyroid hormone levels. In patients with hyperthyroidism, no, um, undergoing anti-thyroid drug therapy, let's say you have a patient with Graves' disease, you decide to start the patient on methimazole, you want to know if your treatment is working, the only test that you will request is FT4. So you don't need to request your TSH. No? You can request FT4 maybe as early as a week or two, or sometimes a month, depending on the urgency of the testing. So again, no need to always measure both in monitoring response to treatment because again, unnecessary tests cost money and resources. So if it's hypothyroidism or levothyroxine, you request for TSH. If it's central hypothyroidism, meaning the problem is from the pituitary, the patient is on levothyroxine, you check FT4, not TSH. If the patient is hyperthyroid, you're already treating with anti-thyroid drugs, you only check FT4. You don't need to check TSH. Okay? So I will ask this in the exam. How about radioiodine uptake and thyroid scanning? So this is the diagnostic test of choice if you want to know whether the patient has endogenous hyperactivity such as in Graves' disease, or if you want to differentiate between Graves and let's say subacute thyroiditis or Hashimoto's thyroiditis, if your patient has increased uptake of your radioisotopes, no? So in radio uptake and thyroid scanning, they give the patient radioisotopes, and those radioisotopes, either iodine 123 or iodine 131 or technetium, it will go to your thyroid gland and they will scan you, and if there's increased uptake, then that's your Sometimes there will be selective uptake. Let's say this one, no? There's an increased uptake in just one nodule. So this is your toxic adenoma, and the rest of the thyroid gland will be suppressed. This is also a hot nodule, no? A hot nodule, there's in thyroid gland. This one is a cold nodule. There's decreased activity, no? There's decreased uptake in a nodule. So these are non-functioning or cold nodules. It can Before it used to indicate malignancy, but now it's can be both benign or malignant as long as the nodule is not secreting excess thyroid hormone or does not have increased iodine uptake. No, you can have both. You can have both hot and cold nodule, or this one there's no uptake. If there's no uptake, so probably the sodium iodide symport is already destroyed, and these are your cases of thyroiditis. So if you're not sure whether your patient has Hashimoto's or Graves', the thyroid scan is a very useful test to determine. No? If there's no uptake, that's thyroiditis already. So your anti-thyroid drugs is not indicated. So your radioiodine uptake, another nuclear medicine test that we use in endocrinology is your iodine 131 whole body scan. So usually used to confirm thyroid remnant ablation. So for example, your patient has thyroid cancer and the patient undergoes radioactive iodine ablation. So you use radioactive iodine to remove all the remaining thyroid cancer cells or even thyroid cells in the body. No? We scan the patients after the radioactive iodine therapy, and we will see where the radioactive iodine went. No? So if there is an uptick there, then you know that um, this confirms the thyroid remnant ablation. No? There are also some upticks in other parts of the body that can be normal. So this is a iodine 131 whole body scan of a patient with multiple thyroid cancer metastases. So we also use iodine 131 to monitor patients with thyroid cancer. No? So in monitoring response to therapy. So for example, after 6 months or after a year, you suspect the patient to have you're monitoring for thyroid cancer recurrence, then you can do a iodine 131 whole body scan to detect whether there is recurrence or if you're suspecting presence of metastasis. No? Because it's only your iodine, your thyroid cell that um, will predominantly take up your iodine 131, aside from your physiological uptake that I mentioned earlier. And lastly, your thyroid ultrasound. Very important test in thyroid dysfunction is recommended for all patients suspected of having thyroid nodules either by PE or another imaging study. Let's say you have a thyroid incidentaloma from a CT scan. No, that happens also. So you still have to confirm with the thyroid ultrasound because thyroid ultrasound is the best imaging of choice in this type of patients. No, it's very good with determining certain patterns suggestive of either malignancy or benignity. It can also help us monitor nodule size, and it can also help us in doing procedures. When you want to do fine needle aspiration or you want to aspirate cystic lesions, your thyroid ultrasound can help you also with those procedures. So this is a transverse view of the thyroid gland. This is your trachea, and this is your this is your left thyroid gland and your right thyroid gland, and this is your isthmus. And this is a longitudinal view of your left thyroid gland if your probe is placed like that. So this is a thyroid ultrasound showing a large thyroid nodule, and as you can see, it's hypoechoic, meaning that the density is lower compared to your normal thyroid tissue. It's inhomogeneous because there are certain areas where there will be more hypoechogenicity, and you can see also that there are irregular borders. So this nodule, because it's large, are all characteristics of a nodule that has potential for malignancy. And true enough, this turned out to be papillary carcinoma. So when we go to your session on thyroid nodules, we'll talk more about this. Okay, so this is the end of part one. So I expect you guys to review the anatomy and physiology of thyroid gland on your own. And watch out for the next part, the part two of our session on disorders of thyroid, disorders of the thyroid gland. Thank you.